Hi, it's really great to be here and good to see you all. So I've been given the post-lunch siesta slot, so hopefully it won't lull you off to sleep. And really, I've been given the task of talking to you about health inequalities, but I wasn't able to be here this morning and looking at those fabulous drawings over there, and I can see that you've done quite a lot of this stuff, so I'm hoping it's not going to be a lot of repetition, and if it is, it's from a slightly different perspective. So I think I need to start by caveating this by saying inequities, disparities, whatever your preferred term is, happens across access, experience, and outcomes for every ethnic group. And they vary between groups as well as within groups. So it's not uncommon that, for example, South Asian is seen as a group, but if you look at the inequalities within South Asian, it varies tremendously depending on whether you're Indian or Pakistani or Bangladeshi, okay? And then there are obviously some very specific conditions that are linked to certain types of people, certain groups of people, so things like sickle cell anemia, thalassemia, and so on. So there are certain things that we need to maybe pay particular attention for in certain groups. And it's quite shocking that we're still having people dying in hospital from sickle cell anemia because people don't know how to treat it after all this time. We also know that inequalities occur across the lifespan. So if you're unfortunate enough, and I'm going to use that very advisedly, to be in utero to a mother who is homeless or very, very young, or have a problem with substance misuse, or a whole range of different things, your chances of being born early, small for dates, and all the things that predispose you to having a lifelong health inequity are already set, even before you're born. Okay, so many of you will know the phrase that Michael Marmot coined, social determinants of health, and I'm not a fan of that phrase, not least because it feels like it's a fixed thing. That if you're born in these conditions, it's almost like it's your fault. You're poor, and you're born in these circumstances, and that's your lot. And it kind of lets some of us off the hook from doing anything about it, I think. But nevertheless, what he was trying to capture is that health doesn't happen in a vacuum, and ill health doesn't happen in a vacuum. And there are things that we can do that would change the picture for people, but it won't happen by itself. We have to be intentional. And we also know that health inequalities are amplified by a range of things, including, and sometimes we call these intersectional factors, so things like ethnicity, like gender, age, all of those protected characteristics. And we also know that there's this thing that Tudor Hart coined years ago called the inverse care law, which means that the people with the worst health are also the ones who are least likely to be able to access good quality health care, and they're the ones who are most likely to have poor outcomes. Some of you might recognize this guy. So just to say that, because we haven't got long, and I really want to have a conversation with you, so I'm going to talk about one example from mental health and one from physical health, and hopefully that will help us to ground our conversation. So does anybody know who this is? I haven't got a prize, so. No? So his name was David Rocky Bennett. And David died in forensic mental health services back in 1998. And this is one of the things that was taken from his inquest, that it was a struggle. He had a struggle by up to, nobody was quite sure, but at any one time, that up to 5 nurses pinned him on the floor face down for at least 28 minutes. And even though he was saying he couldn't breathe, that's how he died. And rather ironically, that's what they told his family, that he died of breathing difficulties. So no mention of being forcibly held down and restrained. And during the inquest, what they also found, there were lots of stuff around his medication. So he was on 3 lots of antipsychotic medication, only two of which had been authorized by second opinion doctors, which is supposed to be standard practice. And one of the doctors that gave evidence at the inquest talks about him having higher medication than almost anything she'd ever seen. Okay, so we might want to wonder why that might be, and I might talk to that in the next slide. Out of David's death in services, there was an inquiry. So you'll see there's a bit of a gap, isn't there, between 1998 and 2004, when eventually there was a public inquiry. And that came about because of his sister. So she was a nurse, Joanna Bennett, and she was tireless in campaigning to find out what happened to her brother and how he came to die. And it clearly wasn't just breathing difficulties. And out of that, we ended up with, do you remember when we had a series of czars? Do you remember that? See, some of you are very young, you don't remember that. But we had the first ever clinical director, national clinical director, some of you will know him, Lewis Appleby, and he became the mental health czar. And his job was to address the inequities that were clearly in services, in the mental health services, that were linked to race and ethnicity. And out of that inquiry and out of that piece of work that Lewis led, there was this series of programs of work. There's a whole policy around delivering race equality in mental health care. And it was a 5-year plan. So within 5 years of 2005, we were supposed to have had a mental health service which was devoid of health inequity based on ethnicity and race. So for those of you who are working in mental health services, I'll leave you to decide how far we've traveled. And I think, so I put this in as a bit of a provocation, because whenever we have an inquiry, like with David, we always hear about lessons learned, okay? People are always going to learn lessons, aren't they? That's one of the things we'll say, but it was terrible, but we've learned some lessons. So before David's death, there'd been a report, a previous inquiry, that was labeled the Big, Black and Dangerous inquiry, because that's how a lot of people were categorized. People like David were categorized in services, even when they weren't particularly big, but as long as they were black. That was the terminology that was given to them. And there's been a whole series before, then, and since of people who've died in psychiatric services in exactly the same way that David was. And some of the recommendations that came out of that 1991 report included things like staff training and making sure that people knew how to manage violent incidents, making sure that staff knew how to do resuscitation. One of the things I think that was for me was just fascinating, and I can't quite get my head around this even now, is that one of the key recommendations is that just one black person should be appointed to take particular responsibility for tackling the problem of racism in specialist psychiatric hospitals. So there were all these problems, and one black person's going to turn up and fix it all. Okay? So the other thing, one of the main conclusions from the report was that this wasn't new. All the things that they found were not new. And so this is going back to the 2004 report that came out after David, and the conclusion from that was that no or insufficient action had been taken to deal with problems in the mental health services that have been recognized for years. Again, for those of you working in the system, I just ask you to reflect on the extent to which things have changed. So moving on to a physical health example. So in thinking about maternal health. So overall, the death rate for women during pregnancy and early motherhood, so the perinatal period, is about almost 13 per 100,000. If you're white, it's about that, but slightly less. If you're Asian, and by that, predominantly they're talking about South Asian. Okay, so we'll maybe come back to the data and why people from East Asia are often missing from these kind of conversations. So about 1.3 times. If you were black, it was 28.2 women that would die, so it's about 2.3. That's this year. But in 2020, the risk of dying in maternal services if you're a black woman was 5 times greater. Okay, so that's in 2020. So just leave you to ponder that for a moment and look at what's happened. So that's 5 years ago, it was 5 times, and we're now at 2.3. Okay. So maybe just take a little bit of a step back and think about what are the things that drive inequalities in patient safety. So some of the consistent themes that come out of research in these inquiries are things like, so we know, and I mentioned Tudor Hart earlier on, that in the areas of the country where there is the greatest need, and particularly where those areas are ethnically very diverse, you're likely to have fewer GPs. So your primary care is likely to be not as good. So a lot of the preventative stuff that stops you being at higher risk later on is not happening, or it's not happening to the same extent as if you were in more affluent areas. And linked to that was a whole constellation of biases, and this is partly why I really struggle with the social determinants. So I understand the concept, but the way that is operationalized means that often it's because they don't speak English very well, they are obese, they were in the care system, so there's a whole load of stuff about why some certain people might not do well. And that is when that intersectionality is when those different characteristics that we have, personal or social, coincide to actually amplify our risk of inequity. And linked to that, despite the fact that we talk a lot about holistic care and individualized care, it doesn't always feel like that when you're the person on the receiving end. And that means that some people are at greater risk than others of falling through the net. So this is a busy slide, so I'm hoping you can see some of the things that I really want to point out. So if you look at the very top, when it talks about being ready for pregnancy, so this is around just under 900 women who died in the pregnancy or in the early perinatal period in the latest Embrace report. And what you'll see right up here, is how many of these women had pre-existing physical health conditions, which we know would predispose them to greater risk. Okay? And we also know that in terms of the intersection between physical health and mental health, so we know that people with mental health problems are significantly more likely to have physical health problems, and they're likely to die on average, depending on what kind of condition, 15, 20 years sooner than somebody who doesn't have a mental illness, particularly if it's a serious mental illness. And we're not talking about suicide, we're talking about health-related conditions. So you'll see that a lot of these women, I'll go back, had mental health difficulties. And a lot of them probably had comorbidities, so they had mental health and physical health difficulties. And that affects their risk in two ways. One, they are less likely to present during pregnancy, because especially if you're a woman who has a history of substance misuse, you know that increases your risk of your baby being taken early at birth. So a lot of women don't. So they end up coming into services, usually in labor, having had no prenatal care. That is not uncommon. Okay? And then down here, the thing I really wanted to point out was this one. Where is it? So, the do not speak English bit. It's a relatively small number of people. I'm not saying it doesn't matter, but very often our default for dealing with inequity within services is that we just need to enable people to speak better English, and then it will all be fine. And that's not what this slide suggests. And the elephant in the room often is systemic and structural racism. We're not talking about the individual racism that patients and staff and might hold. We're talking about stuff that's baked into the system in a way that it becomes invisible. It's just part of the way we do things. And that influences that's all the way through leadership, through management, and all the way through to the way the workforce operates. So, again, going back to some of these consistent themes. So bias and stereotyping. So some of you will know, we've read this particularly, and this is one of the things that came out of the maternal health inquiry, is that black women who were asking for pain relief were not being given it. And I don't know if some of you saw during the pandemic, it was on social media, there was an African-American physician who had COVID. So this is a doctor, right? So she was telling people that she was really ill and nobody would listen. And they weren't listening, to the point where she eventually was going to discharge herself. Now, that's the point at which they actually did some further investigations, and by then she had bilateral pneumonia and she was really unwell. And they prescribed her medication, and she didn't get it. So the next hours later, she's saying, I haven't had my meds. And the nurse said to her about, there are lots of other people who are really ill, and you just have to wait for your narcotics. So there's that thing where people just make the assumption, and that coupling of, it's not that you need pain medication, it's that you just maybe you're addicted to substances, and that's why you want medication. And so we have this paradox of some people sometimes being over-medicated, as in with the mental health services, show the example for David Rocky Bennett, or under-medicated, and that's linked to stereotype and biases. Some of the tools that we have are just simply not effective at picking things up. So, for example, spirometry, that was calibrated because there was many, many moons ago, it was decided that Black people's lung capacity was very different. So it means that some of us just don't get the right medication and the right diagnoses. But some of that then rolls into what becomes evidence-based practice. And we don't often challenge some of the things that we see, and we think it may not be quite right, but we don't challenge them. The inadequate training. So again, some of you will remember in 2018, a young medical student, Nigerian origin, who realized that he was doing dermatology, that none of the textbooks that he was using showed what it was like to have a range of skin conditions on Black and brown skins. That was 2018. We've been doing medicine for a very long time, right? All around the world. So those textbooks didn't just not exist here, but not anywhere. And we also talk very much about cultural competence. And I don't use that phrase, that's why it's in quotes, because we're not going to be competent in everybody's cultures. We're not. My family from Jamaica. We barely get on with the people from Barbados. And we don't understand we don't understand them at all, let alone somebody else who might look like me, but might come from Ethiopia or somewhere else. It's very different. So they're not the idea. Anyway, I've alluded to the lack of or poor quality data. So there are lots of groups of people who don't appear in our data, or when they do, they kind of get rolled into other groups because the numbers are too small to do anything meaningful statistically. And that's one of the reasons why, for example, there's lots of gaps around people from white minorities, East Asian, people are often not there. And one of the things that we don't think about when we think about data is that data is not just the numbers, that people's stories are also data, because we're talking about their lived experience. And the other thing is that very often, in terms of the themes, is that when people raise concerns, whether that's patients, whether that's their carers, or whether that's colleagues, they're often dismissed or minimized or not addressed at all. And what really shocking example, at least to my eyes with this one, is in NICE. So remember I mentioned the maternal health thing. So when NICE saw that Black women were 5 times more likely to die in pregnancy and childbirth and early motherhood, and it was about 3.5 times for South Asian women and similar for women of mixed heritage, their response wasn't to fix the system, it was to fix the women. So by inducing them at 39 weeks, irrespective of whether they had a complicated pregnancy, that was their response. And that's at the highest level, that's NICE. So, coming down, because I've got my warning, so what can be done? So I think I'm advocating a solutions-focused approach where we do stuff like this and we have the conversations that raise awareness, and that it's really important that wherever we have the influence, whether it's at policymaker level or board level, that we really make sure that we put this on the agenda. And I really think we need to move away from cultural competence to thinking about cultural humility. How do we talk to people about their experience? So culture comes in different forms, not just about ethnicity. I've got colleagues who are deaf and they've got a completely different kind of culture. So we need to think about those things and move on to really co-creating the healthcare that we all want, also the measurement tools that we need. Thinking about our data, so I know we can see statisticians in the room, and about how we can improve the data quality to make it much more useful. Some of our ethnic categories now are maybe not fit for purpose. And really importantly, in terms of this conversation, is how we think about complaints. So maybe if we could change our culture a little bit to see complaints as being a positive thing. If nobody's complaining about our services, it doesn't necessarily mean it's great, it just means that they don't complain. And as I mentioned, thinking about lived evidence, so people's voices. And I'm really positive that we can do something to shift the dial. So I'm going to show you this so 5 Times More started this campaign, and they were told that Black and ethnic minority people don't get involved in research, that we don't do stuff. But within a matter of months, they'd managed to galvanize 187,000 people to sign a signature, to get their signature onto documents that then push the government to do a maternity safety inquiry, 2 parliamentary debates. They launched an APPG and began to raise the issue with professional services. And you see that from within 4 years, they'd gone from 5 times to 4 times. To 2022, it was 3.5 times, to 2.9, and in 2025, it's 2.3 times the death rate. So something shifts when we're intentional. And this is what the latest 5 Times More book, their report advocates, is if you fix the system for the people who are most disadvantaged, you're likely to get a better system for everybody. And this is what Black women were telling people, that about 2/3 of them felt that the services that they received were good during pregnancy and childbirth, but over half had experienced challenges with healthcare professionals. More than a quarter had reported discrimination. Almost a half raised concerns during labour, of which half of those were not addressed. A quarter, again, didn't receive pain relief and didn't receive an explanation. And importantly, only 20% of them were told about how to complain if they weren't happy with the care that they received. And of those, only 8% did so. So, come down. Health disparities are not new. We have an NHS that was founded to eradicate health inequalities. That's the whole purpose of it, so that people didn't have to choose between food and medicine, okay? But they've been hidden in plain sight, haven't they? So we've become quite accustomed to knowing that if you live in London, you live longer than if you live in Manchester. That's just become a thing that we've accepted. So I think in order for us to think really seriously and be intentional about promoting patient safety, we have to become learning cultures. Forget about the lessons learned. We have actually got to do the learning. And that means we've got to embrace safety concerns, learn the lessons from near misses, complaints, and sadly tragic outcomes to do something about it. And somebody's got to be accountable. I'm not talking about blame culture, but know that somebody has responsibility for this. And I think this is where commissioners can have a role. So if commissioning was really about transforming services rather than something transactional, buying more services, and building in things like patient safety KPIs into our agreements, then maybe we might move things forward a little bit. And importantly, taking an assets versus deficits approach to talking to and listening to patients, their carers, and frontline staff. So involving all of those end users throughout the process of co-creating safer services. And never forget the power of storytelling. Thank you.